Good evening. Welcome to tonight's webinar, Cementation Protocols for Provisional and Definitive Placement of Indirect Dental Restorations. My name is Dr. Robert Lowe. I practice in Charlotte, North Carolina, coming to you this evening. And I'd like to welcome everybody that's joining us for tonight's presentation. Also like to give a hearty thanks to GC America for sponsoring this program and this hour of CE credit for everybody. Our first topic is going to be provisional cementation. And of course, the provisional phase of treatment is an extremely important time for both the dentist and the patient to evaluate function and aesthetics, particularly when major changes are being made to their oral cavity, their teeth. And for some patients, this may be an extended period of time. Now, for whoever came up with the magic 14-day turnaround in dentistry, as far as between preparation and delivery, I don't know where that came from. I mean, you go into a laboratory and all of the bins have on the prescription Rush. I know Rush is one of my favorite rock bands, but I never really want my laboratory technician to have to rush to meet a deadline, because the final restoration, once it's in, is we know there's nothing that's really final, but we want to have as fine a product as we can deliver, and sometimes that means taking a little bit more time, doing try-ins, doing aesthetic evaluations, and during those periods of time, a good provisional has to be serviceable for the patient, and cementation is a good part of that. A little bit of history on provisional cements. Initially, the first provisional cements, and a lot of them still on the market today, are zinc oxide powder and eugenol liquids. These date back to the 1890s. And ZOE as a temporary cement, anything with eugenol, really with today's materials, really is a problem as far as the reactivity with today's final cementing or cement medium, particularly resins. So to address the challenge of setting with resin, eugenol-free cements were created. Initially, non-eugenol cements did not set as rigidly, so many manufacturers had to add other ingredients to make these cements set better. As far as the category of ZOE temporary cements, some of the advantages, well, the obvious advantage of anything containing eugenol was sedative to the pulp. A lot of times we create transient hypersensitivities when prepping teeth, and having eugenol-based temporary cement would help to sedate the pulp and allow it some chance to recover without the patient having sensitivity issues. Also decreases inflammation and actually acts as a good, the ZOE acts as a good seal against microleakage. Disadvantages, though, are low strength and fracture resistance, high solubility, extremely easy to wash out around margins. And with today, the use of composites and composite buildup-like materials, ZOE is contraindicated under those particular products. And because of the solubility, it doesn't stick around very long. So the non-eugenol temporary cements, if you look at that category, the advantage obviously then without the eugenol is that it can be used, the product can be used under resins or resin ionomers. There's no taste or smell like the typical dental office smell from eugenol, and there still is a good seal against microleakage. But you still deal with the disadvantages of low strength and fracture resistance, solubility, and problems with sensitivity, since the eugenol now has been removed and the cement does not stay where it's put, particularly in long cementation provisional type cases. So we started looking at resin type temporary cements. Excuse me. The advantages being that these products did produce a higher strength and like their final cementation counterparts, insoluble in oral fluids and create an excellent bond to tooth. This also did create a disadvantage in making the provisionals a little bit more difficult to remove, and when dealing with composite cores and buildups under in some crown and bridge situations, you could end up having the temporaries chemically bond to the resin core in the teeth and then pull out the resin cores when removing the temporaries. So obvious disadvantages for those types of cements. What I'd like to introduce you to tonight is a relatively new temporary cement called Fuji Temp LT, and it's one of the only glass ionomer provision luting cements that I'm familiar with in the market, if not the only. And glass ionomer cements have been around in the dental market for a long time, and one of the main advantages of glass ionomer technology is the fluoride release, because if a patient is going to have a provisional on, usually these margins are not as well sealed as definitive restorations made in the laboratory. So the chance of oral fluid seeping in and under the provisionals are extremely common, and to have a cement that releases fluoride in those areas just makes good sense to serve as a protective base or a means of protection against the ingress of bacteria while a patient is in provisionals. Some of the features and benefits of this product: excellent handling, low film thickness. Now, film thickness 6 microns is a good film thickness for a final cement. Usually the space between laboratory fabricated restoration and the tooth can be anywhere from 20 to 30 microns. We consider that a good fit. So 6 microns of space taken up by the cement is not a lot of space, and unfortunately a lot of the provisional cements are quite thicker, and these types of situations or types of cements that have a higher film thickness do not allow you to seat the provisional fully and create issues with adjusting and whatnot. So a low film thickness, I think, is a very good feature to have. As you see, I've highlighted easy to clean up in red. That's because to me that's one of the more important features of a provisional cement, is that it's easy to clean up off of the acrylic or bisacrylic or rubberized urethane or whatever material you're using for provisional restorations. The typical ZOE type of temporary cements are very difficult to clean off these surfaces. They tend to smear and are difficult and take a lot of time for the dentist or the dental assistant to clean them prior to dismissing the patient after cementation. High bond strengths. I think bond strength is one thing that, particularly in cases where preparations may not be ideal taper or axial height, bond strength is critical. Thermal insulation to prevent sensitivity is again another nice feature, particularly because there's new eugenol. Good thermal insulation and decreased sensitivity is a good feature to have. High fluoride release and recharge. This is a unique feature from Fuji Temp LT, I think, that is really something that is very desirable in a provisional cement. Again, because most provisionals don't fit so well, to have the ability to release fluoride at the marginal interface and protect that area from any possibility of bacterial contamination, recurrent decay, etc., is a good benefit to have. No adverse effects on final cementation, as commonly found with eugenol, and easy cleanup from the preps. One thing that a lot of dentists will bring up in lectures when I've talked about cementation, they think it's important that the temporary cement come off in the temporary and not stay on the tooth, because a lot of dentists choose not to anesthetize their patients for delivery. I'm not one of those dentists. Having been a dental patient myself, having exposed dentin hurts. In today's world, when we're using total etch and other types of medicaments, whether it be etchant or desensitizer or antimicrobials or whatever, we're rinsing and drying and doing all these things. When the teeth are alive, that's a problem. It's not fun to be the patient having a delivery of a multiple unit case without anesthesia. So for me, it's more important that I have a provisional that actually stays cemented until I need it to come off, not having a patient call, for example, at midnight on a weekend is important, saying that they lost a temporary. So easy to clean off from preparations. I use an ultrasonic scaler and clean off any little bits of provisional cement that may be left on the tooth. Fujitemp LT is really easy to handle. It comes in a dual barrel syringe that you can mix easily on a pad within a few seconds, load your provisional in place. The one interesting thing about this particular product, it has the highest fluoride release of any of the cements in the category, provisional or otherwise, which again, as a provisional cement, I think is an added bonus. So here we have a case from our office that we did last year, a lady that had short, worn down maxillary incisor teeth, and because of lack of overbite and overjet, and if you look at the gingival display and the gingival zenith heights over the centrals, they're a little bit too incisal. So the slide on the right, you see I've used a fine tipped tissue marker to mark gingival zeniths, which I then use a diode laser in this case to give a little bit of aesthetic crown lengthening. Since we want to have a normal width to length ratio of about 75 to 80%, we're going to need to increase the height by taking away a little bit of the tissue and by adding some of the tooth structure to the incisal edge and creating overbite and overjet to allow proper anterior guidance and canine disclusion. So here's our patient after the initial diode surgery has been done with the laser. I had a stent made from a pre-operative model that we did a composite mock-up on. Did the surgery on the model and added a little bit of flowable composite to increase the length of the teeth on the model, and made a suck down from that. And from that suck down, filled it with bisacryl in this case, and made a provisional restoration. Extruding some Fujitemp LT onto the mixing pad, mixing it with a spatula. We load the restoration. In fact, now you can get auto mixing tips and put it right on to the Fujitemp and squirt it right into the teeth, or into the provisional. And after about a minute and a half, we go in with an Explorer or a scaler or ultrasonic scaler and clean off the excess around the margins. Again, this peels off very easily. And you see with the perio probe there, I'm just sounding to crest of bone to demonstrate that no bony crown lengthening was needed in the aesthetic crown lengthening of this case. Going in and doing a little touch-up with the all-surgery laser, just to make sure that our tissue levels are where we want them to be. And then here you see the provisional restoration after it's been cemented and the patient is released. She wanted to see what a little bit of brighter color would be, and so we gave her a lighter colored provisional material. And you can see the change in the width to length ratios of those particular anterior teeth. So let's move on now to definitive cementation. I want to talk about a couple of different materials in the realm of definitive cements. You see, we basically have two different categories of cements when we're looking at definitive cementation. I call category one conventional cements, where we mix, place in the restoration, and seat the restoration. Starting from the top, you see zinc phosphate cement, followed by polycarboxylate cement, then glass ionomer, resin modified ionomer, and finally self-etching. If we start at the top, it goes from 0 megapascals of bond strength to the highest bond strength with a conventional cement being in the self-etching realm, and those can vary anywhere from 10 to, 15 to 18 megapascals of bond strength. When you look at total etch you are looking at a single cement in that category, and it's resin cement, and it's used in conjunction with a 15-second etch with 37% phosphoric acid, followed by a 15-second rinse, and then placement of a 4th or 5th generation bonding adhesive. And you can find resin cements in 2 categories: dual cured, one type that has a light cure activation and also a dark cure for full coverage restorations where the curing light can't penetrate thoroughly, and light cured resin cements used primarily for porcelain and indirect composite veneers. When you look at bond strength, I think it's a critical thing to understand, because there's a lot of messages out in the manufacturing world about my bond strength is bigger than your bond strength type of thing. And really, to me, the most important thing is resistance and retention form. That's what holds a restoration on, not how many megapascals of bond strength. We remember zinc phosphate had 0 bond strength and has been used successfully for many years. Now, the main problem with zinc phosphate is that it was soluble in the oral fluids. When you look at the preparation, I think there are a couple of things to remember. And this slide came to me from Dr. Mark Latta, who is the Dean of Creighton University, and Mark being an expert in the field of dental materials. Comparing the heights of preparation and comparing conventional cements versus the additional quote-unquote retention you get from total etch and resin cement. Now, most preparations, in order to get a good cementation result, you need to have at least 3 millimeters of axial height and a 5 to 10 degree taper for any of the conventional cements. If your preparation is shorter, if the taper is greater, doesn't mean you can't cement with a conventional cement, but make sure your contacts are tight, because preparations with excessive taper or short axial heights are very likely for the cements to fail at some point. Minimal preparation height for a resin cementation and total etch, you can see you can have a little bit more taper with a total etch, but you see only a 0.5 millimeter in difference, 2.5 versus 3. So you're only getting a 0.5 millimeter out of more retention out of using a total etch and resin cement than you are using a conventional cement. You see, it's all in the prep. Resistance and retention form are the most important thing, not the strength of the specific luting agent. So if we look at this slide from Dr. Latta on permanent, that we call definitive cements, increasing bond strength to tooth structure top to bottom, we see zinc phosphate at the top, which is soluble. Polycarboxylates chelated to dentin, but they were soluble. Glass ionomers bonding to dentin, but soluble. And resin reinforced glass ionomers really were the first insoluble definitive cements that we had, which also release fluoride. And resin reinforced glass ionomer cements are very popular cements to this day. Self-adhesive resin cements, a little bit more bond strength to dentin. The question is how well they bond to enamel. And when you look at your conventional crown prep, again, go back to zinc phosphate. How much enamel is there to worry about bonding to? Resin adhesive systems, I said when you're using total etch, there is enamel, like in a veneer, very critical. So you see increasing bond strength from top to bottom. Or increasing right from 0 to the most retentive at the bottom. This again is a slide from Dr. Latta showing a summary of crown retention, percent retention versus a sample of zinc phosphate 100%. You see the varying number increasing as you go toward the self-adhesives and the resins, showing that more of these crowns were retained when comparing with the pool of zinc phosphate. So some of the selections, and clinicians are confused, because many are not aware of all the parameters that affect cementation in the system, and the various selections for different materials. In some materials you can use either a conventional or a resin-based cement. But primary factors, again, prep design. How much mechanical retention is there? Is the area easy to isolate? You know, if you're using a total etch resin system, you need to be able to isolate and keep moisture away from the preparation during cementation. Adhesive preparations, quote unquote, the 10 to 15 degree taper, they're a little bit less retentive, but if you're able to isolate, you can use a total etch and get a good, in conjunction with a resin cement, and get a good result. Which ceramic systems require total etch? Well, feldspathic has been conventionally or universally taught that these types of systems, such as porcelain veneers, feldspathic veneers, require total etch for proper placement. If you look at the prep design, mechanical for conventional cementation, if the prep has adequate resistance and retention form, non-adhesive cements or low bonding cements may be used. Glass ionomers, resin reinforced glass ionomers, one-step resins, zinc phosphates. However, the additional variable again is the ceramic selection. Emax, for example, is a popular material today, and there's some controversy whether or not that can be conventionally cemented or whether it should be bonded. As far as adhesive prep designs, if adhesion to two structures required or preferred for enhanced aesthetics, use etch and rinse, a total technique, or in some cases self-etching are perfectly good alternatives. Where's the difference? Again, a veneer should be etch and rinse with total etch. A full coverage restoration, you have the option of either system. Just keep in mind etch and rinse cement systems or total etch with resin cements are the most technique sensitive to use, just like when doing any other bonded procedure. You get the highest bond strength, and you can cement all types of ceramics with these. But just keep in mind the technique sensitivity issue. Self-etching resin cements have the highest bond strength of conventional cements. Originally indicated for aluminum oxide, zirconium, and those types of systems you see listed here. They're easy to use, no total etches involved, and high potential to cement crowns without anesthetic if you so choose. As I said, that's not one of the things that I look for as a big plus. But if you've got a situation where isolation is difficult, the environment is not ideal, and you want the highest bond strength, the self-etching resin cement can be used. So let's look at a couple of cases and highlight uses of some of these cements. First case, using a resin-modified glass ionomer cement in Fujisem 2, which is really a new material that GC has introduced to their cement line. Fujisem being around for a long time as an example of resin-modified glass ionomer. Another one you may be familiar with from 3M, Vitromir. I mean, there are several of these cements on the market. Most are familiar with Fuji products, and Fujisem has a definitive cement for porcelain fused to metal and other types of ceramic systems. Zirconium being another example of a different system. Fujisem 2 has some nice advantages over the original product. Number one is the delivery. You'll see that the syringe delivery now is really been greatly enhanced for the dentist with the auto mix tips and with the light pink barrel syringe versus the heavy metal syringe and things like that. And having a dual barrel to mix this material and make it very simple has been a nice added bonus. Here we have a 5-unit bridge. You can see it's porcelain fused to metal, pontic in the first molar area. And this particular clinical case I chose to splint really because the crown root ratios on the premolars were less than ideal. And you can see we have endo in the second premolar with a cast post, So you're not going to gain a lot by using adhesive cements on a cast metal post, although we do have significant ferrule effect there. But I do want to also point out and I'm going to highlight the cursor here so that you can see, look at the prep design. This isn't a prep design course, but when I teach prep design, a lot of dentists think that's just going back to dental school, but the design of the prep is just so critical. And we live in a business where the tenths of millimeters mean the difference between success and failure. So having two planes of reduction, having enough reduction in the central sulcus so that you can see an even thickness of 1.5 millimeters to 2 millimeters of clearance between the opposing crown and bridge. This is critical to having success with any type of restoration. So here's an incisal occlusal view of the preparations after the provisional's been removed, and any residual provisional cement also removed. This patient is ready for cementation. Now normally with a conventional cementation, after removal of the provisional cement, as I said, with an ultrasonic scaler, I'll use an antimicrobial like tubulacid red or Concepsus, or even a desensitizer like Gluma, to cleanse and clean the dentin and seal any tubuli, etc. Now a couple of technique points on the new and improved Fujicem 2, called Flex Fuse technology. Just look at the monomers that are used to create this cement. These are much more flexible by virtue of elastic cross-linking monomers, much more flexible than in the original Fujicem chemistry. So it's able to absorb more flexural issues and more load. The higher flexural strength allows it to act more like a shock absorber, better resisting the challenges of occlusal load. We move to the next slide. The modified filler surface treatment. This creates a stronger bond between the glass particles and the resin matrix, also helping to improve the longevity of the cement in the oral cavity. Then I think this is an interesting slide because it's comparing Fujicem 2 versus Fujicem 1 and showing the significant increase in both shear bond strength to enamel and dentin. Here, if we look at the original formulation of Fujicem, it's showing 8 megapascals of bond strength to enamel. Fujicem 2, almost up to 16. And if you compare to dentin, the original formulation, 2 megapascals to dentin versus 6 megapascals with the new formulation. So significant advantage in the formulation of Fujicem 2 really does make it a new and improved product in the resin modified ionomer category. So here's the product. As I said, I'm taking a wet cotton pellet and using tubulacid red and cleaning off the preparations. Using the auto mix tip, injecting the Fujicem 2 mixed directly into the restoration, and then seating the restoration with firm pressure. Now, I think one mistake that a lot of us make is trying to clean up the cement too quick. I like to hold the restoration in place for at least 60 seconds with good, firm finger pressure. By the way, that's my dental assistant's glove. She wears the pink gloves, I wear the blue gloves. I take the pictures. But she's holding this in place for 60 seconds. I don't just have the patient bite down, because sometimes they bite unevenly and they can dislodge the restoration from seat, and then only to have them open and find that it's cemented perfectly on the buccal, but it's tipped a little bit and open on the lingual. That's not a good day. So hold it firmly with finger pressure for about 60 seconds. Then I have the patient bite down. The material still hasn't reached a gel set yet. Have the patient bite down. Just again, it's and I instruct them to bite down slowly until you feel your teeth touch. Open again, then I place a cotton roll between the restoration and the opposing teeth on both sides, so the patient can squeeze evenly on the cotton roll on both sides and then just hold until final set is achieved. I don't clean up Fujisem 2 prior to it being totally set, because it's so easy to clean up. After that final set, you can take an Explorer or a small scaler and just pluck the excess cement away from the marginal areas. You can get floss threaders through and the sonic scalers and clean up the cement very easily and very quickly. So that covers cementation using resin modified ionomer cements. Now let's look at another case where we're using self-etching resin cement, another conventional cement. The NOAA technique is a name I came up with. I don't know how many of you are familiar with the comedian Bill Cosby, but I grew up listening to Bill Cosby, and he talked about Noah in the building of Noah's Ark and the animals going in 2 by 2, and that's where I came up with this, because the cases I'm going to show is a multiple cementation case, but I choose to cement 2 by 2. I'm going to go to a quick question there from Anthony. Are you using Fuji conditioner prior to cementation? Actually, here's the thought on using the conditioner. Conditioner is a mild acid, polyacrylic acid actually. It's Duralon liquid. And really what that does is it doesn't remove smear layer, but it acts as an antimicrobial. So you could use that, Anthony, in the place of the Tubulacid Red or the Gluma or whatever that I show using prior to. You could certainly use the Fuji conditioner, and it would do the same thing. So I'm not going to tell you not to. I'm just going to say that there is an option there. So let's move on, and here we have two all ceramic restorations. I'm starting to get a few more questions, and rather than take up a lot of time, I will answer Dr. Shaw's question. How about using Gluma prior to cementation? Is it suggested? Yes. Anytime you've got dentin exposed, desensitizers such as Gluma are I think, a good thing to use. They don't interfere with bonding. And for patients with sensitive teeth, I think anytime you got exposed dentin, you have the potential for sensitive teeth. So not a problem. Here we have two zirconium restorations. Actually lava cores with porcelain pressed to the zirconium core. And two central incisor preparations. And basically, for isolation on these types of things, I use cheek retractors that I use to take photographs, and my dental assistant with a high volume suction and air water syringe. So we've got significant isolation here, or adequate isolation. Remember, with any glass ionomer product, you don't want to over desiccate the teeth. So just make sure they're dry, but not overly dry. And this particular cement here is GSEM, and it's GSEM in the capsule form, which is activated by pushing that little yellow button, and then you mix it in a triturator for 10 seconds and place it in a delivery, not like a gun, but there's a delivery device, and you squirt it into the tooth. Today, though, I pretty much use the auto tip delivery for the majority of cementations. And with the auto mix GSEM, that makes life a lot easier. I'm not really going to get into cementing veneers in respect to shades of cement, because it's a little bit outside the scope tonight in a short hour, Renee. But I will mention that I do not try to influence the color of the restoration based on the shade of the cement. I really want my laboratory to handle the shade. So if I got a dark prep, I take stump shade photographs. I take photographs of the prep with the shade guide, with a stump shade guide. I use Vita's Easy Shade computerized shade taking device to give shade information so that the technician can sufficiently use a material to block out the shade and give me a neutral color. I want to cement with a neutral color cement. I don't want to have to try to influence the color of the final outcome based on the color of the shade of the cement. I've just never had good success with that. So anyways, back to this case. In one indication on dark preps, if you've got dark endodontically treated teeth, I'm going to give you another little opinion of mine that I think is good basis in clinical fact. Some people believe that the tertiary amines in dual cure cements, resin cements, cause discoloration of the cement over the time, changing the color of the restoration. And it never made sense to me how a 10 micron thickness of cement could have enough pigment with any tertiary amine, whatever, to change the color of a restoration that's at least a half a millimeter to a millimeter thick and has opacious dentin porcelain between the cement and the outside of the tooth. I will submit to you, it's not the cement that darkens over time, it's the teeth that darken over time. And I have redone many cases for patients because they wanted to change the colors of their teeth. And I can show you pictures of the preps that prove that the teeth have changed color, not the cement. So sorry, long-winded answer. I've got a little bit of time. But I want to talk to you about using the resin, the self-etching resin cement. Again, I fill the crown directly, place the restoration on the teeth. You can see my dental assistant holding that in place. Hold it in place for at least 60 seconds. That's not enough for a gel set. But again, we tend to want to get in and clean up this stuff too soon. To maximize the bond strength on a self-etching resin cement, do not disturb the set for at least 60 seconds. Don't be brushing and cleaning and moving the tooth and what have you. You'll interrupt the bond. Hold it firmly in place and don't move for 60 seconds. Then you see I take a camel hair sable brush, remove excess. After 2 minutes of gel time, gel set, you can take an Explorer and remove excess. Very easy to clean. This patient was a full arch case. Again, a little bit too much to talk about in our short period of time as far as to how we get to where we're going. Just the short version of that story. This is a vertical recapture case. A vertical dimension is a muscle position, not a tooth position. If we go back to removable prosthetics, and Dr. Earl Pound, and we place and size the edges based on phonetics, 55, 66. We understand what freeway space is. Somebody like this patient, Class 2 Division 1, narrow constricted upper arch, 100% overbite. When this patient says 55, you could almost drive a Mack truck through the space between the upper and lower teeth and the posterior. In other words, there's a lot of freeway space that we can use. Dr. Harold Chevelle, who I think was one of the finest reconstructive dentists ever to practice, talked about finishing cases to the closest speaking space, again referring to Dr. Pound and freeway. So we work out this freeway space in provisionals. And this patient was put in provisionals. I usually don't prep the second molars, only because I've got a way to get back to my original vertical dimension should I need to. But here you can see, in dental school, they told us, oh, you can't put porcelain back here. You wear down the lower teeth. Well, yeah, look at the wear down here. The wear down here is from the narrow, constricted arch. It's from inadequate preparation, I'm sure, on the lingual surfaces because these crowns were adjusted through the porcelain to the opaque, down to metal. They're not polished well. So, and with this type of situation over years and years and years, this was the result. So in order to build these teeth back up to normal, we've got to recapture some of the lost vertical dimension, and we do that with provisionals. So what you're seeing here now is the delivery, the cementation of this case. This NOAA technique, or 2x2, is not just for a full arch case, which I'm demonstrating here, but you can use this for any cementation situation involving multiple teeth. Because I look at occlusion as a three-legged stool. You've got one point of anterior contact between the upper, lower, and central incisors, or one area of contact, and then another area of contact on each posterior side, the most farthest back terminal tooth, in this case second molars. So you've got a point of contact here, you've got points of contact here when the restorations are in place, and point of contact here. Now the upper arch, as we know, doesn't move. The lower arch does move, and when you put restorations on the lower arch, we'll discuss how this technique will help you identify occlusal prematurities and adjust at cementation. So we've got the provisional restorations off of this case. You see the second molars will be prepped later. We're using GSEM in this case, self-etching resin cement. The restorations are zirconium, lava, with pressed Emax on top. And the essence of the technique is this. I cement two at a time. Now listen carefully. You just don't cement two and let them set and then cement the next two. I've done that before and I've run into problems. And that's where the essence of this NOAA technique comes in. I cement 8 and 9. I cement the two central incisors, 1, 1, and 1, 2 for the international folks. I place the resin cement in those two teeth. The excess runs out the sides. I remove the excess with a brush. There is no cement on the lateral preps. I place the laterals on those preparations to hold positional space for the central incisors while the cement sets. Why do I do that? Because there's micro movement. Even if you've tried on all of these teeth and they tend to fit passively, don't be tempted to cement them all at once. I used to practice with another clinician who would go out and lecture, and they say, oh, practice, you cement them all at once because then you have trouble with the contacts if you don't. Well, that should tell you something. Even on a solid model, when teeth aren't cemented, they will microscopically move to accommodate the tooth next to it when sitting on the model. So micro movement is your enemy. In order to make sure that these two central incisors are seated properly when the cement goes in, you set the laterals on the preps, their respective preps without cement, and then they're going to be positioned properly. And then we wait for the 2 minutes. Is Emax pressed zirconia okay with the FDA? As far as I know, Todd, I'm not a materials expert, but I know that our technician has been pressing Emax or zirconia for several years. So you might want to ask one of the lab techs on that. I don't know, but I assume that it is. Hold these in place for at least 90 seconds. After 90 seconds, I remove excess. I light cure at margins. Now, before cementing the lateral incisors, you see there's a little area where the tissue appears to be, it's not bleeding yet, but it will be. I tend to intervene in those areas with this green putty called Expasil. If you're not familiar with Expasil, it's a cord retraction or a cord alternative for retraction for final impressions. I use it for tissue management. It's one of the best tissue management things out there. If you get a little bit of bleeding, don't pack a cord in there and get it all stuck in the resin cement. Stick a little Expasil in. Sit it in there for a minute, then rinse it out, and the tissue's deflected away. If there's no bleeding, and then cement. The laterals and the canines are placed on the preparations to hold positional space. Here you see using the tubulacid or gluma or whatever conceptus that you want to use, or a medicament to cleanse the preparations prior to cementation. Here I'm demonstrating using the sable brush to remove the excess cement from the distal of that cuspid so that I can set the premolar in position and hold positional space while the canines set. Here the canines are cemented, and while I'm waiting for areas here to get initial set, I may go back in the first few crowns that were cemented with the sonic scaler and carefully remove any little bits of free resin cement that appear in the proximal areas. Kelly, that's a good question. Have you ever had an instance where I had residual cement on the laterals? Yes, that's very critical. You don't want to have residual cement. I use 4.0 loops, and I make sure there's absolutely no cement on the adjacent teeth before placing them to hold positional space. If there is a little bit of cement and you don't pick it up, there is definitely a concern for that. You just got to make sure that they're clean. I've done this technique for years now, and as long as there isn't an excess, a drop of excess cement on the adjacent teeth, you can get them off with no problem. But Kelly, very good question. Very good question. So now we've done 2 by 2 by 2 by 2, going all the way back to that first molar, and I guarantee you, even if they all fit passive initially, that contact with the second molar is going to be tight. So I go back, I check it with floss, it is tight. I go back to the master model, mark the contact on the unit with articulating paper, and make an adjustment with a porcelain polishing wheel. Then go back, check, make sure it's seated, contact is good. You can see I've bent my brush here to gain proximal access to remove excess, just showing another little clinical tip. And with this case now, we cemented the entire upper with only a slight adjustment on the distal of the first molars. The lower is still all provisionals. Now when I did the initial try-in, I had the patient close lightly on all of these units at the passive try-in to make sure that my occlusion was going to be in the ballpark. Now I said this could be for any case, and it absolutely is. If you're just doing 3 or 4 single units down here, let's say you're doing 3 units down here on the lower right, you've got natural teeth contacting here, natural teeth contacting here. Maybe you have a third contact here, or you have a free end. In that case, let's say we're doing 4 units here. I would place the one closest to the joint, have the patient bite down slowly. If there's contact here and here, then you place the next one forward, and so on. If you place that most posterior unit and you have open contacts in the other 2 areas, you obviously have identified the prematurity, and you make the adjustment. Now we're going to the lower. This is not an excellent case, but follow me on this description, because this patient had a lot of wear on these anterior teeth, so I chose to splint these teeth together. This is a 4-unit zirconium splint. The patient also had a very short first molar, lower left first molar, so I chose to splint that to the lower left second premolar. Normally I would try in 2 centrals if they were single units, and 1 on each side, the most posterior unit, and look for the patient to bite down. Slowly, they should bite down and hit those 3 points simultaneously. If they hit the posteriors and no anterior contact, I take out 1 posterior on either side and see if the front teeth touch. If they do, I've identified the unit that is premature, and I adjust it. If they don't, then both posterior units need adjustment. Here's the case before cementation. I cemented that bridge because you see the second molars here are touching, so I got 1 contact, 2 contact, 3. Now we're going to go from the joint forward. I try 1 posterior unit in here, the most posterior unit. Here, remember, these 2 are splinted. I try those in, and I check with articulating paper, and you can see I've got a strike here in the distal buccal cusp of the upper first molar, and here on the mesial palatal of the upper first molar on the contralateral side. This is a class 2 patient. So remember, deep bite. There won't be any contacts on the centrals, but there should be contacts on the laterals, which there are not. So I took one of the units out and still did not have anterior contact. So you can see on the lower, here are the areas where the hyperocclusion is happening. I adjust the ones that I can take out of the mouth, 30 micron diamond to adjust, and then polish, and then go back, try in again with articulating paper. Now, Dr. Chevelle used to refer to this as an occlusal lock. You can see when you're talking about tripod contacts, we have B contacts between opposing stamped cusps right in here. And then we have an A contact between the upper palatal cusp and the lower lingual cusp. And we have a C contact. I'm sorry, it's reversed. That's the C contact. We have an A contact between the palatal incline of the mesiobuccal cusp of the upper first molar and the buccal surface of the lower first molar. So you can see a nice, good occlusal lock here on that particular tooth. We check with articulating paper. I've got a faint mark here in the lateral. I've got a strong strike here. Remember, there are teeth missing here and here. The ones that we're trying in back here have good heavy marks. So now we go and add a tooth on each side. I put one in here, and I put one in here, and I check again. If everything is even, if the anterior teeth are touching, I'll put that single unit in and try again. If not, I'll adjust. But here you see now we've got everything adjusted and polished into proper intercuspation, except for the lower cuspids. Lower cuspids, tight. Remember, I tried them all in at the same time before we started cementation. They all fit passively. Obviously, they're not passive, which again is a good indication that those of you that are out there trying to cement all of these in at one time, you're going to run into these issues. So you see the contacts are a little bit tight. We're going to take and actually right in the patient's mouth, I'll put a piece of articulating paper in next to the distal of the lateral, try to seat this unit. It'll make a mark on the side of it. You see I go back. Now this is a good little tip here. Place the restoration on the die. You see I hold my thumb with on the incisal edge to force that down on the die so that when I'm spinning that wheel, the thing doesn't fly across the room and break into a million pieces. If you're just trying to adjust it in your finger without putting on the die, believe me, it can be difficult. So we adjust that with the porcelain polishing wheel. And then finally cement the lower cuspids. You can see here in place. Here's the full upper arch, full lower arch. We're going to come back later and do the second molars. Now, one thing Dr. Chevelle also said, precision is more important than position. The precision in immediate anterior guidance, any movement from the centric occlusion relation position should cause immediate separation of posterior teeth during function. Here you can see a canine rise on the right side and anterior coupling with the remaining anterior teeth. Patient goes into left lateral, same thing, canine guided occlusion, anterior coupling. No balancing interferences. And full protrusive, contact on both centrals simultaneously, picking up the laterals lightly. Here's where we started. You remember the amount of wear. People always ask me, well, did you put them in a night guard, an occlusal guard? The answer is yes. But you know what? Occlusal guards are for us, not for the patients, because most patients don't wear them. Ask your patients. At least if they have an occlusal guard and they don't wear it and they break their ceramic, you can say, you know what, you got to pay for that again. And with Mr. Richter, I told him, I said, you know, we need to put you in a guard here. You saw what happened to your natural teeth and your old crowns. You know, there isn't anything man-made that's going to hold up any better than your natural teeth. You need to wear this guard. He said, Dr. Lowe, I'm going to be honest with you. I won't wear that. I said, no, you don't understand. You need to wear that because you're going to break these things and we're going to have to redo them and it's going to cost you more money. He said, if I do that, I trust you. If I break them, I'll pay for them again. I'm not going to wear that silly thing. This has been almost 9 years. I just saw Mr. Richter this last week on recall. He doesn't wear his night guard. Here's where he was when we delivered the original units. You can see the amount of opening back here in the second molars. He had had enough with us, and we didn't go back and actually restore those second molars until a year post-op. Unfortunately, they did not super erupt into place. But here's the restoration after a year, and we did the second molars. And as I said, he's into his 9th year now, not wearing a guard, not have broken anything, not wearing anything down. Just a model patient. And here's where he is, completely finished. So what we've done in this short period of time is reviewed with you a couple of cases on cementation with various materials. One a resin-based material, one a glass ionomer resin-modified material, but both in the conventional area without total etch. And about the only thing I'm using for total etch, you know, the only systems, the only restorations I'm using total etch now are for porcelain veneers. And it's not because I don't think some of these self-etching systems are going to be sufficient. I know some of the self-etching bonding agents now are improving to get a better etch on enamel. So time will tell.